Good morning, everyone, and thank you for allowing me the opportunity to speak with you at the IMSA California State Stroke Summit this morning. My name is Andy Southerland, and I'm a vascular neurologist at the University of Virginia in Charlottesville, Virginia. And I want to thank the conference organizers, both Drs. Nasser and Dr. Bosan, as well as Jeff Saver, for giving me the opportunity to speak with you today on the role of telemedicine in pre-hospital stroke care. I have a few disclosures, largely research support for some of the work we're talking about, as well as some industry support for a pre-hospital stroke trial that we're not going to be talking about, and some non-remunerative intellectual property on some of the technology. So what are our learning objectives? Well, in the next few minutes, hopefully I can help those who perhaps are not as familiar with the idea of ambulance-based telemedicine understand the why and the how of how this could help us enhance our pre-hospital stroke systems of care, particularly in the endovascular era. And then, of course, within that, discuss some of the challenges to feasibility and implementation of an ambulance-based telestroke system, both locally as well as abroad. And then finally, our Q&A at the end. So going back a few years ago, we published this Controversies in Stroke paper in Stroke, talking about the idea of whether or not patients with suspected large vessel occlusion should be transported to the nearest primary stroke center or bypass to a comprehensive stroke center for endovascular therapy. And at the time, we argued that based on our current paradigm, that we should be taking stroke patients to the nearest available primary stroke center. And that is commensurate with what's published in our most recent acute ischemic stroke guidelines. But if you fast forward, I think that this question has evolved, and more we're becoming comfortable with the idea of creating workflows that could help us make smarter decisions in the field about where we take our stroke patients. And I want to reference here the Mission Lifeline Stroke pathway that was recently published by a number of colleagues to sort of help provide some guidance potentially to EMS on how you might triage patients with large vessel occlusion stroke. And specifically, if a patient's identified in an LVO stroke screen as positive and it's less than 24 hours from last known well, and importantly, less than or equal to 30 minutes from the nearest available comprehensive stroke center or thrombectomy capable center, then it provides an outlet potentially to transport that patient directly to the endovascular capable center. The challenge, of course, with the workflow is in the identification of the large vessel occlusion stroke. And that, of course, is challenging if you're not used to seeing stroke patients on a regular basis, and particularly more sophisticated signs and symptoms of LVO stroke, such as aphasia, hemineglect, visual field abnormalities, et cetera. And if you look at LVO stroke scales, there have been a number of them that have been proposed and validated and published about over the recent years. And at least a couple of years ago, within the systematic review of LVO stroke scales at the time, in parallel with our most recent acute ischemic stroke guidelines published in 2018-2019, the authors determined that based on our current level of evidence, that no scale was able to predict LVO with both a high enough sensitivity and specificity to not avoid over or under triage of stroke patients in the field. So where does that leave us? Well, it leaves us with needing more innovation and more tools to help make those decisions in the field. And that's where pre-hospital telemedicine comes in. So this is not a brand new idea. If you can go all the way back to the late 1990s to some work led by Marion Lamont in Baltimore at the University of Maryland, looking at the idea of telemedicine on ambulances. At that time, of course, it predated our current endovascular systems of care. And the goal then was to decrease the amount of time that it would take to treat a patient with IVTPA or thrombolysis by performing the NIH stroke scale and the neurological exam before the patient ever got to the hospital. And while I think this was really trailblazing at the time, it was not really for prime time in the sense of our technology and cellular environment was not sophisticated enough to really make this feasible and generalizable. And if you go back a little more than 10 years ago to some of our earliest scientific statements on the evidence of telemedicine within stroke systems of care, led by authorship from Lee Schwam, who's speaking at the summit today, they also comment that real-time audio-visual telecommunication to perform stroke screening in the pre-hospital setting is likely technically feasible, or certainly will be going forward, but the usefulness is uncertain and further research is required. And we see a number of feasibility studies over the last 20 years really trying to answer this question. Again, that original study in Baltimore, and then a number of studies in Europe that had mixed results related to feasibility. And then our first study in the United States by the group in Houston, looking at telemedicine along with the mobile stroke unit. And then we published one of our earliest feasibility studies back in 2015, specifically looking at ambulance-based telemedicine, the absence of the traditional mobile stroke unit, and then all the way most recently with colleagues at MUSC in Charleston, South Carolina. And I know that there's already a great talk on mobile stroke units before me, so we won't talk about them at great length, but you know, it goes without saying that the main limitation of widespread generalizability of mobile stroke units is in the cost efficiency. And clearly telemedicine is one way to help avoid having to have additional staff on the ambulance and to be able to perform that neurological exam to best utilize the mobile stroke unit. So I want to just tell you a little bit about our ITREAT study, which stands for Improved Treatment with Rapid Evaluation of Acute Stroke via Mobile Telemedicine. When we first started out back in 2013, 2014, we were really just looking at the technical feasibility of being able to do this at all. And then we were able to do some simulation testing over approximately 50 runs, the goal of which was to develop a system that was low cost and easily deployable. And we partnered with colleagues at UCSF and were able, with these initial pilot studies, to show good inter-class correlation of the NIH stroke scale obtained in the back of the ambulance compared to what would be performed traditionally in the emergency room after patient arrival. And the kit we ultimately developed, again, involved components that didn't need to be hardwired into the ambulance, a basic tablet device or endpoint, such as an iPad, Cisco Jabber, video conferencing application, a commercially available HIPAA-compliant system, a rugged sort of cradle point modem, input-output antenna, and importantly, a Bluetooth portable speaker. The audio, it turns out, was just as difficult for us to deploy as the video when it came to ambulance-based telemedicine. And then, of course, the idea of being able to mount it in a way in the ambulance that would be suffice to evaluate the patient, but also not get in the way of the other equipment and engineering in the back of the truck. And then the goal of which was to be able to deploy all this in a standard Pelican case, like a heavy-duty first aid kit that could be moved from ambulance to ambulance. And our ITREAT kit that we ultimately came up with was fairly cost-effective. We could outfit an ambulance for a little less than $2,000. I think important to the feasibility of some of our initial work was best understanding our cellular environment. And I'd convey to anyone out there who's thinking about trying to do this that is really key, is to be able to do enough testing along your ambulance routes to really know where the cellular connectivity, the broadband, is going to be most efficient to provide live stream, mobile rolling telemedicine back in the ambulance. And this is just an example of a heat map along our EMS routes coming into UVA Medical Center. And based on that, we were able to develop a network of 3 hospitals, a primary stroke center, a thrombectomy capable center within our community, as well as our comprehensive stroke center, and working with a variety of different ambulance agencies, largely a mixture of volunteer and career providers. So, and then over a geographic swath, you can see here the distance to our comprehensive stroke center and the distance to our thrombectomy capable center, ranging from 10 to 50 miles. And within that large geography, of course, is all this opportunity to perform telemedicine in the back of the ambulance. And this is just an example of one of my colleagues performing an encounter. Just to give you an example of what this might look like. And this is Brett Snyder, one of our EMS coordinators, who's assisting in the exam and a live patient in the back of the ambulance.
5, excellent. Okay, let's do the other one.
Cataloging score on the NIH stroke scale.
Yes.
But very similar to our traditional telemedicine, except for what's going on the
1.
head. And within that, we were then able to do a little fewer than 60 live encounters with patients, and showed that this really was technically feasible. However, about a quarter of our evaluations were limited not by the connectivity or the cellular live stream data that we were obtaining, but really by logistical constraints such as user error, the battery being down, lack of training in the protocol, and so forth. And so that really surprised us. We weren't prepared to have as smooth of logistical output as we were hoping to. But within our connectivity successes, our median ambulance transport time was 25 minutes, and our median mobile connectivity time was 10 minutes. And this is just an example of our current day workflow that we have translated from those early feasibility tests. And not to go through every step of this, but just to highlight that it really involves a team-based approach, including EMS, medical communications, neurology, of course, and the ED, to really make this all work seamlessly and to limit redundancy within the communication workflow. Again, all going back to those logistical concerns. And happy to say it's been, this concept has been deployed in a number of different geographies, including Honolulu, Hawaii. This is Matt Koenig and Scott Klein out in Western Indiana. So really can be utilized in different environments, again, with the importance of those feasibility testing to make sure it's going to work in your local environment. And also got a little boost in the arm from the Bipartisan Budget Act of 2018, in which CMS expanded the definition of an originating site for telehealth services to include an ambulance or a mobile stroke unit, not necessarily a mobile stroke unit like we think of it with a CT scanner, as has already been presented, but really any ambulance or mobile unit concerned with diagnosing, evaluating, or treating acute stroke. And this is just an example of a paper we published on pre-hospital triage during the COVID-19 pandemic, in which we also argued that telemedicine may help support conservation of PPE, limitation of person-to-person exposure, and interfacility transport. So take-home points, I think we can all agree, and we're learning, discussing today in the summit, of course, that the accurate identification triage of LVO stroke remains a challenge for us, and that ambulance-based telestroke is just one possible solution to this. I wouldn't say it's a one-size-fits-all solution, but that it's feasible, and the generalizability, I'd say, is very much system-specific and requires a dedicated look at one's own network and geography to make it work. And I do think that there's an opportunity in a growing body of pre-hospital stroke research and clinical trials to incorporate telemedicine to better assess its feasibility and efficacy at a larger scale. And I think this is something hopefully we'll continue to see more of. And then lastly, additional policies and legislation likely will further support its implementation, such that we can take the resources that have traditionally been sequestered at the hospital and really put them in the back of the ambulance where our stroke patients need them most. Finally, I'll just finish up here by highlighting some other mobile stroke diagnostics that may further augment our diagnosis of LVO stroke in the future, such as the CerebroTech device that can use volumetric impedance phase shift technique to identify LVO, transcranial Doppler, and then perhaps even a mobile MRI unit one day, which would be really cool to diagnose stroke, but likely also very costly. And then finally, I'll just highlight some work that we're doing using machine learning and AI, actually taking that video data that we get by telemedicine and seeing if we can train an algorithm through computer vision analysis to diagnose signs and symptoms of stroke, such as facial weakness, gaze preference, aphasia, limb weakness, et cetera. And that maybe this will be something else that one day that we could deploy on mobile video-based devices to augment and help support stroke diagnosis, particularly for non-neurology providers. So with that, I'll finish up, and thank you so much for the opportunity again to speak with you today at the IMSA California State Stroke Summit. I want to highlight our team, including my contact information, but also the many people that have, go into the success of our ITREAT program. Sharita Chapman, who's our current director, and Brett Snyder, who's our EMS coordinator, and of course our sponsors. So thanks again for listening. I look forward to discussion during the Q&A session. Thanks so much.